Let's start. So this is about approach to a child with cough, difficulty in breathing or noisy breathing. Now, to introduce this topic, we should know what is cough first. Now, cough is an important defense mechanism of the respiratory system that helps to bring out the infected secretion from the trachea and the bronchi. This is cough. So cough is protective for us. So should we, inhibit this cough? For example, if some child is brought to us, right, and the parents say, "Doctor, my child is coughing for 2 days." Okay, just 2 days. There's no sputum coming out, and it is not that bad. Also, they say sometimes only. Should you prescribe the drug which inhibit the cough to that child or not? Yes. What is your opinion?
Sir, I would go with the cause firstly, sir, because sir, the cough is because of something, and sir, we have to treat that something. Sir, then I think I would
Yes.
go for the cough, sir.
Cause
Yes.
of the cough. First we find the cause of the cough.
Very good. Very good. This is the thing which I want to explain. Excellent. Don't suppress the cough just like that. This cough is there as a symptom. Something is happening in the respiratory tract. I will try to find the cause first, and don't inhibit or suppress the cough. Otherwise, you will not find the real cause there. That is the first explanation. Second, cough is trying to bring that irritant thing out. If I suppress the cough, that harmful thing may remain inside the respiratory tract. So let's not suppress the cough as far as possible. But there are certain exceptions here. Sometimes what happens, the cough is very irritating. The baby is coughing all the time, and it's a dry type of cough. Nothing is coming out. During that time, I may prescribe antitussive agent. Okay, these are cough suppressing medicine. Whereas if cough is productive, I don't give any antitussive substance, because productive means sputum is coming out. Sputum means it is easily infected type of material there. I want more sputum to come out rather than suppressing it. Okay, so this is a very important practical information right in the beginning. Now, cough is elicited by stimulation of receptors which are located throughout the respiratory tract, right from the pharynx to the terminal bronchioles. Or I want to extend it further, right from the nose or nasal cavity to the terminal bronchioles. So cough receptors are everywhere. So any problem there can result in cough. It can be triggered by various inflammatory, mechanical, chemical, and thermal stimuli. So many of the causes are there for the cough. Now, a bit about cough reflex. Now, any reflex has got a reflex arc. Now, reflex arc means there are receptors present. First, there are receptors like cough receptors, for example. Okay, cough receptors. For example, this is cough receptors, for example. So from cough receptors, the nerve which will take the sensation towards the center. Okay, for example, this is the center here. Okay, let me write C for the center. This is the center. So which nerve is this from the receptor towards the center? Which nerve is this? Yes, this is known as
The
afferent nerve. Okay, I'm just asking very general question now. Don't worry. This is afferent nerve A, afferent nerve. So afferent means the nerve which takes sensation from the receptor to the center. The center will analyze what type of signal is this, and then it will send command, okay, to the effector organ. Okay, this E are the effector organ now, effector organ, and this is efferent nerve. This is efferent nerve. Okay, let me write En is efferent nerve, and this An is the afferent nerve there. Okay, So see this. Now, these effector organs are what? See this, larynx and respiratory muscles are the effector organ, and medulla is the center. And what are the efferent nerve now? Vagus and the glossopharyngeal are the efferent nerve. And efferent nerve means again vagus, because vagus is the one which supply larynx, and respiratory muscles are supplied by somatic nerve. Now let me explain again. When the cough receptors are stimulated, vagus and glossopharyngeal nerve will take the sensation to the medulla, which has the cough center. It will give command, and that is carried again by the vagus and the different type of somatic nerve, and then larynx and respiratory muscles will produce the cough. That is the meaning.
Excuse me, sir.
Yes, yes,
Sir,
yes.
is this message come from the brain or directly from the reflex arc by spinal cord?
This is by the medulla. Spinal cord is not involved here. Okay, medulla means it's a part of brainstem. It's a part of brainstem. It is higher up. So cough center is located there. And
Okay,
of
sir.
course, after the command comes from there, remember, for the somatic nerve, it has to coordinate with the spinal cord, because spinal cord gives rise to spinal nerve, and these are the somatic nerve. Let's move on. Now, after this, very basic things which we have to understand. Now, let's come to the topic proper. What are the examples of noisy breathing in a child? Now, the child can produce so many different type of noisy breathing. One of that is called snoring. Okay, snoring. Here. Another is grunting. Third is called rattling. Fourth is stridor, and fifth is the wheeze. So these are the different types of noisy breathing: snoring, grunting, rattling, stridor, and the wheeze. Now, snoring is we all of us snore when we go to sleep. All of us. Some continuously snore throughout the night. Okay, some disturb so much to the other people. They really cause disturbance. And the person who are overweight or obese, they usually snore. But sometimes other people also snore if the position of the pillow is altered or disturbed. So we can snore. So what is the basic mechanism here? It occurs because of oropharyngeal obstruction. And the character of this snoring sound is inspiratory, and it is a low pitch as well as irregular. And this is not a very important type of noisy breathing. We can easily identify it. Grunting. Grunting is a very important, sound, and this is a present when there is partial closure of the glottis. Now, glottis means vocal cord. When vocal cords are partially closed, then only grunting is heard. And this is like a grunt sound. Okay, very small baby, they produce a grunt sound. In case of this, a very serious type of respiratory conditions like hyaline membrane disease. Now, can anybody tell me what is hyaline membrane disease? I'm sure you have heard this term before. Anyone?
Uh,
NRDA, sir, neonatal respiratory distress syndrome.
Yes, absolutely correct. Okay, I just want to hear that term. Very good. So this is, okay, neonatal respiratory distress syndrome. This occurs in premature baby. This is also known as respiratory distress syndrome of prematurity, and this occurs because of lack of surfactant. Lack of surfactant. Surfactant develops at the gestational age of 34 weeks. After that, so if a baby is born before 34 weeks of gestation, there is no surfactant, and without surfactant, surface tension cannot be decreased inside the lung or alveoli, and that results in atelectasis. Okay, or this overall mechanism is called hyaline membrane disease or respiratory distress syndrome of the newborn, and that is the perfect situation where grunting is heard. This is usually expiratory. Now, let me clarify it a little bit further why this grunting occurs here. Now, what happens is there is no surfactant, you all know that. Without surfactant, there is excessive surface tension. Now, to decrease that, surface tension, the baby will try to increase the pressure there, okay, inside the alveoli. And that increased generation of pressure is by partially closing the vocal cord. So when air moves from that partially closed vocal cord, a grunt sound is heard, and that is grunting. So it is very important type of sign of respiratory distress. I'll talk about that so many times when I move further in this particular class, okay, or topics of the respiratory system. Now, rattling is also not very important one. See that it occurs because of secretions in the trachea and the bronchi, and if we do not, do proper suctioning, rattling is very commonly heard. And after suctioning, rattling sound will disappear. Stridor and wheeze are a very, very important clinical type of noisy breathing. So stridor occurs because of obstruction in the larynx and trachea, or you can say bigger airway, whereas wheeze occur because of smaller airway obstruction. One is by bigger airway obstruction, another is smaller airway obstruction. Stridor is mainly inspiratory, but it may have an expiratory component as well, especially if trachea is obstructed or blocked. It may have expiratory component, but if larynx is obstructed or blocked, it is mainly inspiratory. Whereas wheeze is always expiratory. Okay, it is always expiratory, and this is a continuous musical type of sound. That is wheeze. Remember one thing: if wheeze is heard, that means the lower, smaller airway, mainly the bronchioles, are obstructed. Now, what do we mean by difficulty in breathing? So many times we have heard these important terms, but what is the meaning of this here? Okay, see here, the difficulty in breathing, or dyspnea, it is also known as dyspnea, is a subjective sensation of shortness of breath accompanied by air hunger, which occurs in response to hypoxia. This is important point. So subjective sensation of shortness of breath accompanied by air hunger, which occurs in response to hypoxia. So whenever we are hypoxic, whenever we are not having enough oxygen, we have that feeling that I am lacking air. Okay, I want to have a fresh air now. I am suffocating. I cannot breathe properly. That type of subjective sensation or feeling is called a dyspnea or difficulty in breathing. So in case of pediatric age group or in children, how to identify it? Isn't it? Let's talk practically. How to identify? The first thing is they have increased respiratory rate. They are breathing faster than the usual one. Now, one small question I like to ask, and I already taught this in the last semester for your batch. What is the normal respiratory rate from birth up to 2 months? Yes?
Sir, up to 40. Sir, up to 40.
Yes? Yes, please.
Sir, I think it's up to 30 to 40 breath per minute, sir. I think it was like this, sir, up to 40.
Sir, 30 to 38 in children's and 12 to 16 in adults.
Okay, that is your answer. Anybody else? Now, listen here, okay? Maybe it was taught a little while earlier. So without revision, it can be forgotten so easily. So increase respiratory rate according to the age, according to the age. Now, from birth up to 2 months, the upper limit of the respiratory rate should be less than 60. If it is more than 60, okay, it is abnormal. That is important one. Now, from 2 months to 12 months, the upper limit is 50. If it is more than 50, it is higher, it is abnormal. And from 1 year to 5 year, the upper limit is 40. So 60, 50, 40, and the age group 0 to 2 month, 2 to 12 month. 12 month means 1 year, and third is 1 to 5 year. This is a very, very important question which is asked to the pediatric students. And after that, it gradually falls, and when they are about 8 to 10 year or more than that, almost looks like an adult one, 16 to 18 per minute. Now, another important thing here which I like to discuss is head nodding and nasal flaring. These are important features of respiratory distress. A small baby may nod the head when they are having difficulty in breathing. Just with every inspiration, they are nodding the head. This means severe respiratory distress. Another is nasal flaring. The ali nasi muscle, which is there on the side of the nose, just flares outwards when somebody is having difficulty in breathing. This is common in adult also. Use of accessory muscles of the respiration are quite common. Now tell me, what are the accessory muscles of respiration?
Sir, the sternocleidomastoid, the scalene, sir, and sir, the serratus anterior, sir. Apart from this, you've got the trapezius and the internal lateral column, and sir, some abdominal muscle as well.
Good, very good. So he has given the complete answer here. Sternocleidomastoid and trapezius. These are the two major muscles which we can see very clearly on the upper part of the shoulder and the neck area. If these muscles are prominent, means if they are in action when somebody is breathing, that person is really in respiratory distress or difficulty in breathing. And these muscles are helping, the respiratory apparatus for the breathing process. This is the conclusion. Respiratory muscles are the intercostal muscles, and abdominal wall muscles are also the part of accessory muscles of respiration. So they are also, prominently involved if somebody is having difficulty in breathing. Like there is subcostal and intercostal indrawing. Okay, the chest is sucked inside, especially at the junction of abdomen and the chest wall. That area where the diaphragm is inserted, or present, is sucked inside. If a baby is breathing like that, and if you found out this is a feature of respiratory distress, this baby is hypoxic, this baby needs oxygen and the quick treatment. So this is the importance of discussing these features of respiratory distress here. And the added sound like wheezing, stridor, and grunting again add on the importance of this child. Like this child is seriously sick, this child is hypoxic, and because of different airway narrowing, these features are seen. Now, one small point which must be coming in your mind: what about the cyanosis? Now, cyanosis is not a feature of respiratory distress. Cyanosis is a feature of respiratory failure. Means it is a bit late already in case of respiratory diseases. Yes, we are quite aware of the situation. If somebody is cyanose, this is a serious condition, we should give oxygen quickly. But it is already crossing the limit of respiratory distress, and it has gone towards the respiratory failure. But I'm not saying it is irreversible, okay? It is still reversible if we give every treatment in time. Now, with this, let's enter into the easier one. What are the causes of cough? And let's start with causes of acute cough. Now, see here. Acute cough means cough for a shorter duration, usually less than 2 weeks, usually in the clinical practice. Upper respiratory tract infection are the commonest cause of acute cough in children, like common cold, sinusitis, rhinitis, hypertrophied tonsil, and hypertrophied adenoids, pharyngitis, laryngitis, and even tracheobronchitis. So all of these are causes of acute cough. Okay, above the larynx, we call it upper respiratory tract infection, and below the larynx is is the part of lower respiratory tract infection. Don't forget that, okay? Now, one small question I like to ask, probably all these terms are quite easy for you, apart from adenoid. What is adenoid?
Sir, adenoid are the pharyngeal tonsil, or we can say tonsilla pharyngealis, sir, mainly.
Okay, these are nasopharyngeal tonsil. Okay, you need to add nasopharynx there because these are the collection of lymphoid follicle which are present in nasopharyngeal area. So these are called nasopharyngeal tonsil, adenoid. When they are enlarged, usually palatine tonsils are also enlarged along with them, and they cause airway obstruction there and can result in cough. Other causes of acute cough are allergy and asthma, bronchiolitis and pneumonia, measles, whooping cough, foreign body in air passage, and empyema. Empyema is a pus collection in thoracic cavity. Yesterday also, we talked about it. What is the causative agent of whooping cough?
Bordetella pertussis, sir.
Good.
Bordetella pertussis.
Yes. Very good.
Bordetella pertussis, yes.
Very good. Bordetella pertussis. Bordetella pertussis is the causative agent of whooping cough. That's why the another term for whooping cough is also known as pertussis, or we also call it 100 days cough. Okay, 100 days cough because it is some type of chronic illness. But we can write it in the acute phase or acute causes of cough also, because if we treat it quickly, it cannot go into the chronic phase. So some of these disease will uh, develop into the chronicity as well. So I was talking about the causes of chronic recurrent cough. These are the different headings here. Okay, this is the a bit of a detailed discussion. First are inflammatory disorders of the airway, like bronchial asthma, tropical eosinophilia. This tropical eosinophilia is associated with filariasis, the filarial worm. Okay, when it travels in the blood, it also travels through the lung, through the pulmonary capillaries, and during that time, it leads to intense amount of eosinophilia there. And at that time, the patient will have cough and difficulty to breathe. This is known as tropical eosinophilia syndrome. Hypersensitivity pneumonitis is because of hypersensitivity reaction. Second important causes are infection, like viral infection, bacterial infection, chlamydia, mycoplasma, tuberculosis, fungal, or even parasitic. Among them, we are talking about the chronic recurrent cough. Chlamydia, mycoplasma, and adenovirus. I want to take these three names because in clinical practice, if they cause the infection, then that is quite chronic and it is a dry type of cough. Adenovirus, chlamydia, and mycoplasma. Apart from them, tuberculosis can also result in chronic cough, but there are so many other clinical features to diagnose it. Inhalation of environmental irritant like smoke, okay, smoke, dust, and tobacco smoking. All of these are responsible for cough as well. Sometimes what happens, you are not a smoker or that child is not a smoker, but there is a passive smoking inside the home or inside the household environment. And that passive smoking is making that child cough. When you take that child to a fresh environment, cough may not be there. So this may be the cause. After that, there are some suppurative lung disease, which are the cause of chronic cough, like bronchiectasis or cystic fibrosis, okay, or lung abscess. These are the examples of suppurative lung disease. I can add one more here on the list, that is empyema thoracis. These are called suppurative lung disease. First is bronchiectasis, cystic fibrosis, lung abscess, and empyema thoracis. All of these are resulting in pus collection in the lung or in the pleural cavity. One of the important cause of lung abscess is retained foreign body in the bronchi. And foreign body inhalation is very common in children. Third one, are, other groups of causes I should say are anatomical lesions, like vascular ring compressing the airway, and this is already there. Tracheal stenosis, tracheoesophageal fistula, laryngeal wave, okay, cyst or stenosis of the larynx or trachea, and vocal cord paralysis. All of these are certain anatomical lesions which can, stimulate the cough receptors and then cough. Among them, from the exam point of view, tracheoesophageal fistula is absolutely favorite question, and we have already studied that before. This is a connection, abnormal connection between trachea and esophagus. Okay, sometimes they are also associated with esophageal atresia. Psychogenic cough is another cause of chronic cough. There is nothing wrong. Okay, there's nothing wrong inside the lung or airway, so we call that a habit cough. Just the person develops that habit of coughing without any reason. Post-nasal discharge. Post-nasal discharge is very commonly seen in sinusitis. Now, what is this? When you go to sleep or when you lie down on the bed or on the sofa or anywhere on the bench, wherever, sometimes what happens, some secretions from the nasal cavity trickle downwards towards the oral cavity or towards the oropharynx. This is known as post-nasal discharge. This clearly suggests there is sinusitis in the patient, and that is the reason for cough. Gastroesophageal reflux disease is another cause of chronic cough, and it results in chronic aspiration, and that is the cause of cough here. So GRD means the acid which is there in the stomach is refluxing up towards the esophagus, and somehow it is trickling down towards the airway. Now, let me tell a bit of important point here. If this is causing the cough, it will also lead to bronchospasm or airway obstruction because of chronic irritation or burning type of sensation there. And to treat this condition, we have to give certain H2 receptor blocker or PPI type of drug, so that there is decreased acid production in the stomach, and the reflux of the acid up towards the airway would be less, apart from other symptomatic treatment. Now let's move further. These are some other causes of chronic cough. Interstitial lung disease. Now, what do you mean by interstitial lung disease? Yes? Anyone?
Sir, sir, basically, sir, like the tissue that surrounds the lung, which we know call as interstitium. And sir, like for example, like sir, if it is like scarred or inflamed, like sir, pulmonary fibrosis, for example, sir.
Exactly. Yes, your concept is there. Good.
Scarring or inflammation.
Yes, scar or inflammation, okay, on the interstitial area of the lung. Interstitium or interstitial area means area between the alveoli. So that area is involved here, and mainly these are fibrotic conditions of the lung, or pneumoconiosis, you can say. These are called interstitial lung disease. Even sarcoidosis is an example here. Another may be pressure to the trachea or main bronchi by enlarged lymph node, cyst, and tumors which may be present in the mediastinum. So these may be responsible for the cough. Means pressure symptom in the airway. Pulmonary hemosiderosis is another rare causes of cough. And hemosiderosis means deposition of the iron pigment there. Now remember, iron pigment or iron is present in the blood or in the hemoglobin. So if there are certain causes which causes chronic ongoing bleeding inside the lung, that results in hemosiderosis. And one of the common causes is mitral stenosis here. Mitral stenosis. Okay. Now see there. So how mitral stenosis causes this type of problem, you all know. because it causes back pressure, okay, in the pulmonary vein. Pulmonary vein, if they are congested, pulmonary capillary will have excessive blood, then blood may leak outside and results in pulmonary hemosiderosis. Cardiac causes are the other. Now, recently we have talked about the congenital heart disease. Okay, they are definitely one of the causes here. Look this congenital heart disease like VSD, ASD, PDA, endocardial cushion defect. These are the one. And apart from them, pulmonary edema because of left-sided heart diseases, congestive cardiac failure because of any causes, pericarditis, and myocarditis as well can lead to a chronic cough because of lung involvement. Some of the drugs can lead to chronic cough, like AC inhibitor. These are the very, very common causes of dry, irritating type of cough. Okay, enalapril, lisinopril, ramipril, captopril. These are the example. If somebody is having this type of side effect for AC inhibitor, we just replace this AC inhibitor with which type of drugs?
ARBs.
ARBs. Can you give the example of ARBs?
Losartan,
Yes, sir.
valsartan, telmisartan,
Valsartan.
All the certains.
all the
Very,
certain.
very good. All type of sartans. Very good. Losartan, valsartan, okay, candesartan, irvasertan, telmisartan, all these type of drugs. Wonderful. So they do not cause cough. Beta antagonist drug can also result in cough sometimes. Beta antagonist, okay, or beta blocker, you can say. But they are not very common causes of cough, and especially in case of uh, bronchial asthma or COPD or those type of disorders, we avoid these beta blocking type of drugs because we are afraid they further narrow the airway. Abdominal causes rarely can also lead to chronic cough, like diaphragmatic hernia, eventuation of diaphragm, intra-abdominal mass, and massive ascites. The causes are similar here. And the causes is because of increased intra-abdominal pressure, they push diaphragm upwards towards the lung or towards the thoracic cavity. So they constantly irritate the lung, and by doing so, they causes cough. Now, this is a new term for you, eventuation of the diaphragm. So let me explain here. Diaphragmatic hernia means there is a gap or defect in the diaphragm which results in herniation of the intra-abdominal organ into the thoracic cavity, like stomach and intestine. They have reached the thoracic cavity through that gap or defect. This is hernia. Whereas eventuation means the diaphragm is very floppy. It is not stronger. Okay, so that intra-abdominal organ have pushed the diaphragm way up like a tent. There's no real defect or gap in the diaphragm. It is just floppy. So this is the meaning of eventuation of the diaphragm. Other things are quite easy to understand. Now, what are the causes? What are the causes of the cough that need immediate attention? See this. These are serious disorders which results in acute cough, and these are croup. Croup means acute laryngotracheobronchitis. That is called croup. It is always considered a serious disease because there is a chance of hypoxia to the kid. Laryngeal edema. This is a edema of the laryngeal mucosa. It can result in acute airway obstruction. Foreign body inhalation is always serious. Congestive cardiac failure, of course, it results in pulmonary edema. Pertussis, okay, Bordetella pertussis or whooping cough. Bronchial asthma, severe pneumonia, bronchiolitis, and any toxic inhalation like kerosene poisoning. That gas in the kerosene, if the child inhales that, that can acutely cause damage of the airway and can result in pneumonitis. So these are, if these causing cough, we should pay attention a bit earlier and treat the child quickly. Now, more important, part of this class, is physical examination. Now, how to examine this type of child when they come to us? So please pay attention. These are quite important, from the doctor's point of view. When you go to hospital, these are the things which really help you. Now, general examination will include these points. First, check the consciousness level of the child. The child becomes irritable if there is a bit of hypoxia. Mild to moderate hypoxia leads to irritability in the child. And severe hypoxia lead to decreased consciousness level or even coma. This is important point to understand. So check the consciousness level. Check whether there are noisy breathing or not. Check for grunting, check for stridor, and check for the wheeze. If they are present, this is a serious case. Look where there are difficulty in breathing or not by looking at the sign, whether there is nasal flaring or not, whether there is head nodding or not, whether accessory muscles of the respirations are in use or not, whether there is intercostal or subcostal indrawing or not. Recession means indrawing. All of these means the child is in respiratory distress or the child is hypoxic. So this child needs quick attention. Examine for the nutritional status of the child. What is the height? What is the weight? Okay, what is the nutritional status? Are there any vitamin deficiencies or not? Check the vital sign: temperature, pulse, respiration, blood pressure, and pulse oximetry. All of these are very, very important, especially pulse oximetry in this case, because we are talking about respiratory illness. We have to find out what is the extent of hypoxia. Don't forget to check JVP, edema, cyanosis, clubbing, and pallor. These are other parts of our general physical examination. JVP, or jugular venous pulsation or pressure, is high in case of heart failure, especially in case of right-sided heart failure. In fluid overload condition also it is high, and both of these are associated with lung congestion. Examine for lymph node. We always do that. Who knows? This is a case of tuberculosis, and the lymph nodes are enlarged. Now, after doing the basic, general examination, let's go to the systemic examination. Systemic examination, and we focus on the respiratory system exam here. So this examination is divided into 4 parts: inspection, palpation, percussion, and auscultation. So we focus on the chest. We inspect the chest. We palpate the chest. We percuss the chest, and we auscultate it there. So let's discuss one after other. Regarding the inspection, I need to count what is the respiratory rate and what is the rhythm and what type of breathing is it. Is it regular or irregular? Okay. Is it abdominothoracic or thoracoabdominal? In a child, usually it is abdominothoracic type of breathing. Means abdomen is very prominently bulging when the child breathes. And that's how I count the respiratory rate in a child. Always look at the abdomen and how many times the abdomen is rising. Okay, just look at your watch and look at the abdomen and then count the respiratory rate for full 1 minute. If a child is very small, like a newborn, neonate, or infant, I count for full 1 minute. After that, I count for 15 seconds and multiply it by 4. I can do that. But if your examiner wants you to count for full 1 minute, you do that. Appearance of chest. Sometimes the chest is deformed. Okay, sometimes it is abnormal. Can you give me 1 or 2 example of deformity of the chest? Yes.
Scoliosis,
Good.
pictus canatum, pictus excavatum.
Excellent. Very good. Okay. Excellent answer. Kyphoscoliosis, pectus excavatum, and pectus carinatum. So let me write that for you here for the sake of so many other students. Kyphoscoliosis, quite common sometimes. And then pectus carinatum and pectus excavatum. See here. What is the meaning? Let me explain this. Kyphoscoliosis, everybody knows. Scoliosis is the sideway bending of the vertebra. Kyphosis is the forward, okay, bending of the patient, but backward bending of the vertebra. Means acute angulation backward is called kyphosis. Sideway bending is scoliosis. Pectus excavatum and carinatum are the features of sternum. If sternum is, bulged forward, it is called carinatum. If sternum is depressed inside, it is called excavatum. So these are features of, some congenital disorders, or sometimes even rickets. These are seen, and in case of a chronic bronchial asthma from the very early life, these are also the clinical features. After that, we examine for the movement of the chest. Now, the movement of the chest should be equal on both sides when the child is breathing. If one chest is not moving and the other is moving, that means there is something wrong there. Okay, this is the point. Apical impulse is seen. Okay, we check for it whether it is visible or not. Just this is inspection. You don't touch there now. You just run your eyes if I see any impulse there or not. And if we see where is the impulse, which area, we note that. Now, palpation is the second, a part of the respiratory system examination. Palpate for the swelling or tenderness. What is the position of the trachea? Where is the cardiac impulse present? Check for the chest expansion now, confirm it, and look for the tactile vocal fremitus. See there. So these are the different headings. This has to be the first one always. Examine for the swelling or tenderness. If there is a tender point or part in the thoracic wall, we don't do percussion there. The child will cry with a lot of pain, and that is not a sign of a good examiner. Examine for trachea. Trachea should be central normally. But in some situation, trachea is pushed to one side or pulled to the other side. Okay, trachea may be pushed to opposite side or pulled to the same side. Now, what are those conditions where trachea is pushed to the opposite side? Yes.
Collapse.
Pleural effusion, pneumothorax.
Pneumothorax. Sir, when the lungs are inflated and they put pressure on the trachea, sir, like pulling it to the opposite side.
Very good. So I already got the answer from you guys. Excellent. Pleural effusion, pneumothorax, okay, pneumothorax, and hemothorax, or you can say pneumothorax, pleural effusion, okay, and some masses. These are the common causes of pushing trachea to the opposite side, and these are very common disorders. Pleural effusion, absolutely common. Okay, pleural effusion or empyema. You can write empyema here. Empyema is a pus collection. Pleural effusion is a fluid collection. Pneumothorax, air collection in the pleural cavity. Hemothorax, blood collection in the pleural cavity. And masses, all of these push trachea to the opposite side. Now, if trachea is pulled to the same side, what may be the causes? Pulled to the same side. Yes?
Lung collapse.
Lung collapse,
Lung
like atelectasis, for example.
Very good. Okay. Pulling to the same side. One of the important causes, atelectasis or collapse of the lung. Excellent. Excellent collapse of the lung. Another is fibrosis of the lung. Fibrosis. Okay. So these are two important conditions where trachea is pulled to the same side. This is absolutely important knowledge to remember. There are so many causes for this collapse and fibrosis. Now, let's not go into the detail, but if you know this, You can always think about those causes. Now, cardiac impulse in a child, in a younger child, the cardiac impulses or apical impulse is present on the left side in the fourth intercostal space inside the midclavicular line. If it is outside than that, that means there is cardiomegaly. Chest expansion is confirmed with the help of tape, that is measuring tape, or with your examining finger. Just confirm it. And then, okay, ask the child to say 99, okay, and palpate the different parts of the chest and, feel for, vocal fremitus. In case of consolidation, vocal fremitus is increased. In case of collapse or all these pleural effusion, pneumothorax, and things like that, the vocal fremitus is not felt. This is known as tactile vocal fremitus. Okay. Now, after that, we talk about the percussion. Now, see that percussion we examine for pain and tenderness again, because percussion means there is one plexiform finger and there is a percussion finger. Okay, so it is really painful if we keep on percussing over the painful site. So we superficially rule it out. Then there are different terms in percussion, whether it is dull, whether it is resonant, or whether it is hyper-resonant. Now, resonant is the normal lung, because normal lung has got air. So that air present in the normal lung gives rise to resonant type of percussion note. Whereas hyper-resonant percussion note is seen in pneumothorax, because there is excessive air present in the pleural space. And dull type of percussion note is present in pneumonia or consolidation. And one more thing is also there, that is known as stony dullness. Stony dullness is present in pleural effusion. Okay, so we'll repeat this again so many times. Stony dullness, pleural effusion; resonant, normal lung; hyper-resonant, pneumothorax; and simple dullness in pneumonia or consolidation. Another one, percuss for upper margin of the liver. Now, normally, upper margin of the liver is present in fifth intercostal space. So we just percuss in the midclavicular line on the right side, and there is the upper margin of the liver. Now, listen to this question. If this upper margin of the liver is present in sixth or even seventh intercostal space, what does that mean? What does that mean? Yes?
Sir, can you please repeat the question, sir? The voice I couldn't hear.
Okay. If liver is present, if the upper margin of the liver is pushed down, let me say directly, if the upper margin of the liver is not present in the fifth intercostal space, but it is present in the sixth or seventh, means it is pushed down, what may be the causes?
So the
Yes?
diaphragm may put pressure on it. Like sir, for example, like sir, if we have a pneumothorax and there is a pressure on the diaphragm, and sir, diaphragm can put pressure on the lungs, the liver, sir, and that can case also, but sir, I cannot imagine the exact condition.
Okay, no problem. So this is an important question which may be asked to you after you go through the respiratory system exam. Okay, so let me clarify this. Sometimes liver is pushed downwards. That means something is pushing down the liver from upward, and the same causes which push the trachea to the opposite side are the causes here, and they are pleural effusion. Okay, pleural effusion, pneumothorax, okay, or some masses like abscess or pus collection there. Sometimes even the subdiaphragmatic abscess can push the upper margin of the liver downwards. This may be the possibility. Another important point now, if the upper margin of the liver is pulled upwards, that means it is it is caused by fibrosis of the lung or collapse of the lung. So same thing, just like a mediastinal shift. Now, auscultation is another important part of the respiratory system examination. And here we auscultate for breath sound. What is the air entry? Is it equal on both sides or not? That is the first thing. Second, is it normal vesicular breath sound or is it bronchial breath sound? Okay. Normally, we call it vesicular breath sound, where uh, inspiration is longer than expiration. Expiration is just 2/3 of the inspiration, and there is no gap between them. This is called vesicular breath sound. Bronchial breath sound, okay, is inspiration and expiration are equal in length, and there is a clear gap between them. This is a very hollow type of sound, and this is very commonly present in pneumonia or consolidation. You auscultate for added sound. Added sound are wheeze and crackles. Okay, these are important one. Wheezes or crackles. Now, wheezing means the lower or smaller airway are obstructed or blocked, and crackles means there is presence of fluid inside the lung. It's very easy meaning. Presence of fluid inside the lung give rise to crackle, like pulmonary edema, like early phases of pneumonia or resolving phases of pneumonia, for example. Any pus collection there. Okay. Vocal resonance is just like tactile fremitus. So what we do here, we ask the patient to say 99 and put our stethoscope on different parts of the chest, and we listen what type of sound we hear. In case of consolidation, that sound is heard as very loud sound, because sound travels better in a solid type of medium. Whereas if there is collapse of the lung, if there is a lot of fluid which is blocking the transmission or something like that, if the lung is collapsed, lung is not expanding, for example, then we cannot hear this vocal resonance at all. Apart from that, don't forget about other system examination also, like cardiovascular system examination and per abdominal examination, because they are related with the disease process. I can give a bit of example here. Cardiovascular system examination is very necessary to rule out heart failure, to rule out pulmonary edema, left side heart disease, congenital heart disease, like that. And per abdominal examination for hepatomegaly, splenomegaly, ascites, some intra-abdominal pathology, which are responsible for the cough or difficulty to breathe. Until and unless we examine, how we know, isn't it? So these are the important part. ENT examination is always done in pediatric age group. Actually, ear, nose, and throat is a part of respiratory system exam. They belong to respiratory tract itself. And this is quite a challenging type of examination in pediatric setting, because no child wants, their mouth to be examined. They should open their mouth a little bit wider, okay, and they are quite scared when the examiner try to examine their nose examination. Ear examination is another troublesome. So, if possible, we examine this at the end after finishing all other examination, because if the child is irritated and start to cry in the beginning, how can I auscultate the lung? I cannot auscultate the lung in a crying child. I cannot hear anything. I cannot auscultate the heart. So pediatric examination should be opportunistic. Whatever you can examine in the beginning, do it. Okay? And a difficult examination or troublesome examination will be kept towards the end. Okay, nobody would say anything. But in adult, remember that you have to maintain one particular pattern. You cannot jump from here to there. Always one pattern should be followed in adult, and that's what your examiner want. And other systemic examination, according to the etiology, what you are thinking, what is your provisional diagnosis? Sometimes even central nervous system examination is necessary. Sometimes other system examination has to be done. Let's talk about what are the investigation we are going to order in that child who is having cough and difficulty to breathe. See that. Now, the first investigation in any type of respiratory case, in this type of situation is chest X-ray. There's no doubt about it. So, what chest X-ray, what type of information chest X-ray provides to us? See there? In pneumonia, okay, we'll see opacities with bronchovascular marking in the lung. Important thing here are the opacities. The opacities can be there on both sides, can be there on one side, can be the whole lobe, or can be the patchy type of opacities. It depends which type of pneumonia we are talking about. In lobar pneumonia, one whole lobe is opacified or opaque. Okay. In bronchopneumonia, it's a patchy type of involvement. That is the point. And one other thing in pneumonia, which is very, very important, is air bronchogram. Okay, let me write that term here for you. If I see very carefully, I will see air bronchogram. That means inside that white opacity, I can still see some black shadow or black line. These are called air bronchogram. These are very important point there. Now, another one is collapse. In chest X-ray, what are the findings of collapse? There is overcrowding of the rib and there is volume loss. Now, overcrowding of the rib means there is a narrow gap between the rib because they are coming closer to each other. Okay, and volume loss, the overall lung size decreases. The diaphragm is pulled upwards. Okay, the distance between the ribs decreases. So these all thing happens in collapse. Remember, collapse means, what is another term for collapse? Yes. What is another medical term for collapse?
Sir, atelectasis.
Exactly. It's called atelectasis. Good. So collapse or atelectasis means volume loss. Remember that. The third is fibrosis. Now, fibrosis means there is a fibrotic band occurs inside the lung, which has a pulling effect on the diaphragm. So diaphragm is pulled up again. Okay, so this is the important point. And collapse and fibrosis can be easily detected by chest X-ray. Pleural effusion. Pleural effusion is another pathology in the lung in the chest X-ray, and that shows homogeneous opacity with upward turn curve at the upper margin. And in case of massive type of pleural effusion, we have mediastinal shift as well. So there is no CP angle. CP angle is obliterated. CP angle means costophrenic angle, which is there at the bottom, okay, of the lung, isn't it? It is actually formed by, costo means rib, phrenic means, that the diaphragm. Actually, that pleura, which is reflected there, forms the costophrenic angle. So because of the collection of the fluid, that costophrenic angle is obliterated. That gives rise to homogeneous opacity, and that opacity is going upward. When it reaches at the top, there is a formation of upward turn curve in case of pleural effusion. And in a massive effusion, there is a shifting of the mediastinum to the opposite side because it pushes the things to the opposite side. Pneumothorax, okay, is the air collection in pleural cavity. It shows hyperlucent lung field with no bronchovascular marking. There is collapse of the lung actually. This is not lung which is hyperlucent. This is the air collection in the pleural space. The lung in fact is collapsed. So when the lung is collapsed, we don't see any bronchovascular marking. Okay, so at this time it may be a bit difficult for you to understand this, but trust me, when we move further, for example in internal medicine also, if you are learning the respiratory system or anywhere else, these are very, very important point for you. This is how you read chest X-ray in respiratory system disorders. Let's move on. Now, few of the X-ray I have collected here. Now see this. Now look at this area. There is a white opacification at this area here. White opacification at this area. Okay, lungs. There is no mediastinal shift. the ribs are not crowded, trachea is not pulled. So this is a consolidation. Consolidation means it's a pneumonia. Okay, consolidation. Now, on the other hand, look at this side here. This is also white opacification. Okay, in this area. So most probably there is another consolidation there. So this is how we identify it. Now, in this case, okay, see this. This is the CP angle I was talking about, costophrenic angle on the left side. I can still see it, but where is there on the right side? I cannot see it. Means it is obliterated. On the other hand, see this. This area is opacified, and this on the side of the lung. Okay, this line is going upwards till here. So this is a clear-cut case of pleural effusion. Pleural effusion on the right side. Now, what is the connection between pneumonia and pleural effusion? There is a big connection, isn't it? Because pleural effusion can be caused by pneumonia. This is known as parapneumonic effusion. Parapneumonic effusion. It occurs along with pneumonia. So probably a patches of pneumonia is there, but we cannot see it properly here. So this is a case of pleural effusion. Now, let's talk about the changes in pneumonia itself. There are different causes of pneumonia here. See this? The causes can be viral, the causes can be bacterial, and one of the bacteria can be streptococci. It can be caused by chlamydia, it can be caused by staphylococci, it can be caused by tuberculosis, or it can be disseminated type of TB, like a miliary TB. So different types are there, isn't it? Now see there. If it is a viral one, there is overinflation of the lung. Okay, overinflation means there is excessive air collection inside the lung. In today's class, I'm going to talk about bronchiolitis. Bronchiolitis is a viral infection of the lung. So that is also having overinflated lung. We'll talk about that. And there are bilateral symmetrical hilar, increased density. So near to the hilum, there is increased density. So this is typical of viral pneumonia. Streptococci. Okay, one of the streptococci is causing lobar pneumonia. What is the name of that streptococci? Yes, which causes lobar pneumonia?
Streptococcus pneumoniae.
It was pneumonia, sir.
Exactly, Streptococcus pneumoniae. Okay, Streptococcus pneumoniae or pneumococci. Pneumococci causes lobar pneumonia. So when we look at the X-ray, the whole lobe is opacified. The whole lobe, okay, is consolidated. That's why we use the term lobar pneumonia. If chlamydia causes pneumonia, again the lung is overinflated. There is diffuse type of infiltration, and X-ray looks worse than the patient. This is a very, very important term. X-ray looks worse than the patient. In mycoplasma pneumonia also, this is the thing. Patient doesn't look that sick. Patient is having dry cough. There is no fever. There is no sputum, and there is no chest pain. Patient is doing what they are doing before. Means if this is a student, the student still goes to the school. If that person is a teacher, teacher is still doing his or her job, but they are constantly coughing. It is a dry type of cough. When we take X-ray, we are surprised to see that X-ray because it looks much worse than the patient. There are lots of finding in the X-ray. That is the meaning. So this is atypical pneumonia caused by chlamydia. Okay, caused by chlamydia, or even mycoplasma is having similar type of finding. Now, Staphylococcus aureus is one of the most virulent organism. Virulent, okay, means pathogenic. It can lead to localized consolidation in the lung, and it also leads to pneumatocoel. Now, the meaning of pneumatocoel is a small formation of cyst inside the lung which are filled with air. Formation of cyst inside the lung which are filled with air, and of course some exudate will be there, and those exudate can turn into pus in no time. So these can convert into lung abscess. So these are called pneumatocoel, and this pneumatocoel can rupture and lead to pneumothorax also. So staphylococcal pneumonia are considered very serious one. Primary tuberculosis, there is peripheral infiltration, and there is upper lobe hilar prominence, or hilar prominence towards the upper lobe, we can say. So do you know that medical term we use for primary TB? What term we use for primary TB? Yes, there is a
Primary focus or goal
Gone
focus.
complex.
Gone focus or gone complex.
Gone
excellent,
complex, sir.
excellent. Primary focus, or gone focus, or primary complex or gone complex. Excellent. That is called primary TB. That gone complex is a feature of primary TB. Now see this. This peripheral infiltrate is primary focus or gone focus, and that also has a hilar lymphadenopathy. Together we call it gone complex. Very nice. Another one is miliary pattern. There are multiple miliary mottling inside the lung. Small, dot-like structure inside the lung. This is called miliary tuberculosis. So some of the important information regarding X-ray changes in case of pneumonia. Now, if it is a case of sinusitis, we have to take sinus phlegm. Sinus phlegm. Okay, it may see opacification, but very young child, they do not develop sinusitis that often because frontal sinus takes time to develop. It's around 5 to 6 years. After that only probably those type of kids they develop sinusitis. Another one, in acute epiglottitis and retropharyngeal abscess, we have to take lateral neck X-ray. X-ray of the neck, lateral view it is called. Now, what is the importance of this? In lateral neck X-ray, we can see the soft tissue shadow very well. The soft tissue shadow. Okay, so this acute epiglottitis and retropharyngeal abscess can be seen easily there. So always epi view and lateral view, both are included. If you suspect some disorders like tracheoesophageal fistula or gastroesophageal reflux disease, then you can also go for barium swallow study. Barium swallow, we give barium. Barium is a contrast material for the patient to swallow, and during that time we take the X-ray. So these are the diseases which can be diagnosed by barium swallow. Okay, so these are some other information. Now, what are the other investigation apart from X-ray? See that we can go for blood count or CBC. We can look for hemoglobin. If it is decreased, okay, anemia is diagnosed. And in case of chronic respiratory illness like tuberculosis, lung abscess, bronchiectasis, okay, anemia is very common. This is called anemia of chronic disease. Total and differential counts are always part of blood count, and they may be high in infection. Depends on which type of infection we are talking about. In bacterial infection, the total count is high and there is neutrophilia. In viral infection, the total count may be normal or may be high with lymphocytosis. Okay, so these are the different information. And if eosinophilia is there, then this is an allergic type of infection or allergic disorder, I should say. One of the cause which is given here is tropical pulmonary eosinophilia. This is caused by filarial worms, okay, or filarial larva, which is known as microfilariae. If it is traveling through the lung, and it can cause intense eosinophilic reaction inside the lung, that is known as tropical pulmonary eosinophilia. So these are some of the example here. You can include a lot of others also. So there is an important role of doing blood count. So in case of lobar pneumonia, which is caused by pneumococci, see this, the total count will be high and differential count will show neutrophilia. That is one of the interpretation. Blood culture is always done in case of fever or febrile case, cough and fever. If you suspect this is a case of bacterial pneumonia, send blood culture. Throat swab and culture and sensitivity, C and S means culture sensitivity, is done in throat infection, like tonsillitis, like pharyngitis. Who knows, the same organism may be causing pneumonia in a child, so it is better to do. Now, sputum examination should be done. Sputum examination, should be done in case of suspected cases like these. Staining of the sputum is done for gram stain and AFB stain. Now, gram stain is done for bacteria, and AFB stain is done for which organism? We do AFB stain.
Tuberculosis, sir. Mycobacterium
Tuberculosis bacilli.
Acid fast bacilli.
Mycobacterium tuberculosis.
Exactly.
Mycobacterium.
Exactly. It is Mycobacterium tuberculosis, also known as acid fast bacilli, Mycobacterium tuberculosis, which causes tuberculosis in the child. AFB stain can be done if we are lucky. We can see that bacilli there and the disease is diagnosed. Eosinophils in the sputum are present in bronchial asthma and hypersensitive lung disease. Bronchial asthma and hypersensitive lung disease. PMN, okay, means polymorphonuclear cell or polymorphonuclear leukocyte, means another term for neutrophil. They are present in infective causes like pneumonia. Lipid-laden macrophage means these macrophages have engulfed lipid inside them. This is seen in recurrent infection, like recurrent pneumonia. Okay, these are the changes which are seen in macrophages. And culture and sensitivity is done for specific organism. Always, whenever you have obtained sputum, send that sputum for culture and sensitivity. This is a very important, thing, because if culture is positive, we can exactly know which organism has caused the infection and which antibiotics are useful for that organism. That is the meaning of culture and sensitivity test. Now, Mantoux test, you all know, is done for tuberculosis. This is a screening test for tubercular infection. Screening test for tubercular infection. Sometimes, even if the child is having tuberculosis, Mantoux test may be negative, especially if the child is immunocompromised or if the tubercular infection is very severe one. Mantoux test may still be negative. Remember that. Okay. If the child is still having good immunity, then the child will show strong reaction to the Mantoux test when he or she is having tuberculosis. So we'll talk about Mantoux test later on. Arterial blood gas analysis should be done. Okay. Then in case of respiratory failure, in case of sepsis or shock causing metabolic acidosis, there is abnormal interpretation of ABG analysis. Respiratory failure is having hypoxia. Okay, in the beginning, there may be decrease in carbon dioxide level. Later on, carbon dioxide may be retained in the body. Sepsis or shock both can lead to metabolic acidosis, and in metabolic acidosis, bicarbonate level decreases. So all of these can be interpreted according to the ABG reading. Now, some other investigation should be CT scan of the chest. Okay, and this is the investigation of choice in case of bronchiectasis. See here, we call it high resolution CT scan, HRCT. High resolution CT scan, investigation of choice in bronchiectasis. CT scan can easily detect lymph node enlargement and pleural pathology as well. So if chest X-ray is not that informative and you still suspect some other pathology, go for CT scan of the chest. Pulmonary function tests are some other types of investigation, and they are done to know whether it is obstructive type of lung disorder or a restrictive type of lung disorder. Okay, obstructive versus restrictive. In case of obstructive type of lung disorder, the forced expiratory volume in 1 second, which is called FEV1, is prolonged. isn't it? It is decreased, or it takes time for the patient to expire that year. And force vital capacity also decreases. If we take the ratio, it is usually less than 70%. So this is about obstructive lung disorder. And in restrictive lung disorder, the whole total lung capacity is decreased because lungs are contracted. So you will study about these in COPD topic in internal medicine in detail. Now, regarding the immune workup, we can go for immunoglobulin level, and you can go for HIV testing. Now, sometimes what happens, the child is having recurrent pneumonia, and you suspect probably this child is immunodeficiency case. So during that time, go for this type of evaluation. And one other cause is also there of recurrent pneumonia from the cardiovascular system side. What is that? What is that cause from cardiovascular system in a child? Yes.
VSD, sir.
Yes.
Yes, PSD. You're right.
VSD.
Or you can simply say left to right shunt. Left to right shunt. All type of left to right shunt, not only VSD, even ASD, even PDA, even endocardial cushion defect. All of these can lead to recurrent chest infection or pneumonia. Don't forget that. Immunodeficiency is another cause. These are two commonest causes of recurrent pneumonia. Bronchoscopy. See this, endoscopy of the bronchi is called bronchoscopy. Now, it can be diagnostic or it can be therapeutic. Diagnostic versus therapeutic. Diagnostic in the sense we can diagnose what type of disease is there. We can get some sample for the lab evaluation. We can take biopsy from there. And therapeutic means if there is some foreign body obstruction, you can again remove it. That is therapeutic now. Okay, and this obtaining sample is the diagnostic one. This BAL means bronchoalveolar lavage. Bronchoalveolar lavage. Lavage means I give some of the normal saline there, okay, and then I'll suction it back again so that that normal saline is having some of the tissues from there, and I send that tissue to the lab. This is known as bronchoalveolar lavage. This is one of the important things which we do by bronchoscopy.